So today we'll be doing a session on debunking myths, particularly looking at kind of common misconceptions around substance use. So I'm going to focus on a few different themes, but I'll take you through it. So I first wanted to start by just looking at common misconceptions around substance use. So the first one is when we talk about using particularly illegal drugs, there's a lot of misconception around assuming that it's misuse. So I just kind of wanted to point out that not all substance use is actually substance misuse, particularly with illegal substances. And what I mean by misuse is when people use it to an extent that might be detrimental to their physical health, their mental health, or their social environment. And importantly, it's the person who's using the drugs, I think, is if they perceive it as being misuse or not. So I guess I just wanted to use this as an opportunity to point out that most people who use illegal drugs do not view their substance use as problematic or as being misuse, and that's particularly true with young people, so people that are 18 to 25 or younger. I also wanted to kind of address the having one hit of something and you're hooked, so that might be with, say, heroin. So there's a lot of conceptions that as soon as someone uses heroin for the first time, they're hooked and they're going to be addicted to heroin forever. Actually, when people use heroin for the first time, they find it to be quite an unpleasant experience, and they experience feelings of nausea, etc. So I just wanted to address that a little bit. I also wanted to address the notion of being a gateway drug. So that means when some people have a theory that if you use, for instance, if you try cannabis for the first time, then that might be a gateway and make you use more, viewed as like harder illicit drugs. I also would like to address that and say that I think that that is a misconception, particularly as it's difficult to establish a causal relationship between using a softer drug for the first time and using harder drugs afterwards. And if anything, cannabis is viewed as the gateway drug, but alcohol would certainly be more likely to be a gateway drug if that theory were to be correct. So just wanted to point out those things. You guys can think about it what you want. Other common misconception is that junkies or people who use illicit drugs don't amount to anything. So I just wanted to point to these people, notably Nicola Sturgeon, David Cameron, and Barack Obama are all in power at the moment and have all admitted to using illicit drugs in the past. Particularly, there tends to be a lot of politicians admitting to using cannabis or other softer drugs, but Obama has actually said pot had helped and booze maybe a little blow if you could afford it. I inhaled frequently, that was the point. So in this case, Obama's admitting to using cannabis, alcohol, and cocaine, and clearly he has amounted to something because he's current president of the US. So just a little reflection. I also addressed this in the previous session, but I just wanted to have a little bit of a chat around media misrepresentations of drug use. So in terms of common misconceptions might be built around ways that substance use is portrayed in the media. So that might be picking out stories that are newsworthy, such as Leah Betts, who died from what was supposedly ecstasy-related overdose, but was in fact overdose from water, so drinking too much water and her brain swelled. It's just kind of misconceptions around substance users are actually more complicated than that. Or simplifying information or misrepresenting it. So things like talking about legal highs to simplify the term, rather than talking about synthetic cathinones or cannabinoids or hallucinogens. And that can tend to lead to misconceptions. I put a clip of Bill Hicks, but I'll just recount the joke. But Bill Hicks talks about how there's never a good story about an acid trip on the news. They're always going to put the bad stories, like that classic story we've all heard of someone taking acid and thinking they could fly and then like harming themselves by like falling off a building or something like that. And he says we never hear about drug stories that talk about someone's positive acid experience and how they feel enlightened and warmed by other people around them. And I just thought that was quite interesting how the way that the media represents things can lead to these misconceptions. So just a thought on that. Another big one, which I think is quite ingrained in the way that the legal system works in terms of classifying illicit substances, is that the kind of misconception that controlled substances have no therapeutic potential, which is in fact false. If we think about how controlled substances already have therapeutic value, like opiates and amphetamines, like Ritalin or modafinil being prescribed for attention deficit disorders, or opiates for pain management, I mean, I'm sure a lot of us here have taken codeine or tramadol sometimes for pain management, and so clearly these substances do have therapeutic potential. Equally, David Nutt's doing a lot of work around this recently, but prohibition does act as a barrier to undertaking further scientific research around controlled substances and novel psychoactive substances. So that might be things like therapeutic potentials for cannabis, MDMA, or ketamine have all shown evidence of being potentially therapeutic, but again, the kind of ability to research further into this is restricted by virtue of their classification. So again, it's maybe a misconception to challenge a little bit. So I wanted to talk about addiction because I think a lot of the myths around drug use are kind of built on old knowledge around addiction. So if we think about addiction and what I was saying earlier about that, like you have one hit and you're going to be, hooked forever. When you use, when say you use heroin and you take one hit and you're supposedly addicted forever, what that implies is that you have a physical addiction. And what that comes from is experiments that were done in the 50s and 60s, where they hooked up rats to an intravenous machine that was attached to a lever, and they put various chemicals like cocaine and methamphetamine, and essentially allowed the rats to keep pressing the lever until they died. I think that's something that's really stuck in terms of what people's understandings of addictions are. So there's kind of, I think that is the basis of thinking that if you take something once, you'll die, or that the substance itself is the thing that's addictive, notably with cocaine, heroin, other illicit drugs. I think the important part about that, before I explain the next bit, is that these animals were put in cages on their own and were not necessarily given access to the mode of life they would have otherwise had. So, someone called Professor Bruce Alexander started to question the previous experiments in the 60s and started undertaking research in the 1970s, and finally was able to publish his research in 1981. But essentially what he did was he wondered whether rats would respond differently to the experiment if they were put in a different environment. So he made a rat park where they were allowed to, you can see the cages on one side, so they did the experiment as it was before, and then they compared it to this new rat park, where they were allowed to socialize with other rats, they were allowed to have mates, and they were given access to food and playthings. And what he found was that the animals weren't continually pressing the lever and didn't actually die as a result of the substances that were being given to them. And I think that's quite telling. It's a really important bit of information, because if we think about kind of the wider elements, like ability to interact socially with other things, or ability to find joy in other things rather than the substance itself, we actually begin to understand that these substances aren't like you have one hit and you keep using it forever. So I think that's a really important thing to point out. What is now more commonly accepted in the literature, but maybe not in terms of wider perceptions of addiction, is called a biopsychosocial model of addiction. So this is something that previous and current UN rapporteur on the right to health have agreed is the appropriate model of addiction. So it's biopsychosocial in that you have biological aspects, like the original traditional experiment. You also have social aspects and psychological aspects, which all combine into understanding what addiction can mean. So if we just look at the physical side of things, obviously genetic predispositions, disability, illness, or immunity might have a factor in your substance use or the substance itself. But then if we begin to consider things like impulsivity, behavior, personality, or even cultural or religious background, relationships, economic status, importantly, in your peer group, it all kind of, I think it's just a lot more inclusive way of understanding addiction. And certainly all these factors will play into addiction rather than a given substance itself. All right, so I wanted to talk about some drug-specific misconceptions as well. So we'll start with cannabis. There are less deaths associated with cannabis than there have been due to alcohol and tobacco combined. I'll go into that in a little bit, but importantly, there are no deaths associated with the use of cannabis. I think there was a case about 2 years ago where the media reported that someone had died from cannabis for the first time. It turned out to be untrue, but I just thought that was quite an interesting point. Yes.
What actually happened?
It was unfounded, and I believe it was related to polyuse with other substances. So it's the tendency to kind of zone in on like one specific substance, as they did with Leobets, and think it's the MDMA that caused death, or the specific substance that's led to addiction, and actually it can be like a wider range of factors. Equally, as I was saying before, there's no evidence to suggest that cannabis is a gateway drug. There's also no evidence to suggest that cannabis has an impact on long-term cognitive impairment, or it doesn't lower IQs or anything like that, but there's a lot of discussion around those kinds of things. There's also, as I was saying before, therapeutic uses for cannabis that are being explored for fibromyalgia, alleviating symptoms of chemotherapy and glaucoma, and this is now being accepted in the US and other areas of the world. Yes?
There's some, I think, a couple of months ago, there was a paper out looking at it, preventing Parkinson's disease in serious parts of the brain, and some long-term use putting off Parkinson's disease for longer.
Yeah.
So, yeah, like, I mean, there's lots of areas they're looking into, but yeah.
And again, this is what I was saying earlier about when we start to remove those barriers in undertaking scientific research, we start to realize that there's quite a wide range of therapeutic potential for a lot of these substances. Something I really wanted to address in terms of cannabis is there's a lot of discussion around schizophrenia and cannabis use, particularly in young people. What I thought was really important is that to point out that there has been no causal link, so it has not been proved that one causes the other. So the kind of common misconception is that some people who smoke cannabis will have psychosis, which leads to schizophrenia. And I think it's a really important issue to be exploring, but it's also difficult to causally link the two. Yes, Kelly?
I think the new research is kind of, what they've said is that basically if you have kind of the mental health kind of issues, kind of in genetic kind of issues and stuff like that, it's recommended for you not to take cannabis, but it's not, there is no causal kind of link, which is.
So the way that it's explained, to touch on that, is that it's actually it's deemed to be a risk factor.
Yeah.
So things like, for instance, a predisposition to this kind of mental illness would be seen as a risk factor, as would use of cannabis, but it would certainly not be the causal element that causes this to begin in the first place. But it is really important to be advising people that would be at high risk of developing these things that they stay away from cannabis, because it can onset and aggravate these symptoms. Yeah?
Do we know if there's different correlations between what sort of cannabis? So if you have the more modified sort of skunk compared to different various of cannabis, are some more related to this than others, or there's some place high risks? Or
so there has been a lot of discussion around this in the media as well.
Cannabis social clubs, the UK group, they do loads of stuff, and it's great.
Yeah, I wanted to ask Teesside Cannabis Club about this because
they do lots. He does a lot of stuff in that, doesn't he?
There was like a thing on TV, it wasn't done very well, but it was with David Nutt, where they did a comparison between
like skunk and homegrown cannabis, which has a lower THC content.
And they found that the lower THC stuff didn't aggravate symptoms, and that the higher grade stuff had more of a negative effect.
So it's kind of a high grade one.
Well,
it's not necessarily to do with high grade. It's like CBD is like another chemical which actually has the opposite effects of THC. And if you smoke with variety of cannabis that has a large amount of CBD and THC, the CBD kind of can counteract a lot of the more anxiety-inducing effects of THC.
THC has a psychotic effect in the brain, so it can intensify that kind of system that can.
Or even feelings of if anyone experiences anxiety or panic attacks after smoking, certainly having a form of cannabis that has CBT in it would alleviate those symptoms, compared to cannabis that would be like high-grade skunk that just has a lot of THC in it.
But you
So
can get
skunk's a legal high then?
No, skunk is just kind of a higher, a more potent form of traditional cannabis, but it is still illegal.
It's basically all the cannabis that you get on the streets now, 90.
so it's like scientifically modified ones, so they'd be stuck the active ingredient, but they kind of, so just an alternate, so you boost up the one which has the potentially produce negative effects.
Yeah.
Sorry?
Yeah.
They just increase.
Like, you can still get really high grade cannabis that has high CBD, but that's been grown in the lights and stuff. You just have, it just depends what strains they grow. It's just most strains now have been bred to have high THC because people think that's what is desirable.
And again, that's kind of a byproduct of illicit markets and kind of needing to sell a higher potency product and compete with other illicit markets. It kind of perpetuates this thing of like users maybe not wanting such a intense experience, but kind of being forced to because different sellers are out competing each other, kind of thing. And right, with MDMA, I've touched on this as well, but I think there's a lot of the biggest misconception around MDMA is that it causes death. In fact, it's quite rare for MDMA itself to cause death on its own, and I think, in my opinion, because it's not MDMA itself, there's a lot of ways to kind of prevent and reduce the amount of critical or death-related incidents that happen with youth. In most cases, MDMA-related deaths or critical incidents are caused by the presence of adulterants, notably PMA. In some cases, it has been high purity of MDMA, but it is more regular that it's the presence of adulterants. Polyuse with other substances, so using MDMA while you're drinking, or using it because it's cut with other amphetamines, or using it with equipment, obviously is going to lead to more unlikely results and more issues there. Overhydration, like I was talking about with Leobets, which is called hyponatremia. And overheating, because of kind of the way that it's traditionally used in a club setting, in quite a hot environment, and because clubs feel like they're not able to implement harm reduction measures because they don't want to acknowledge that drug use is happening on their premises. I think people can be quite susceptible to that. Yeah, did you have a question?
Yeah, I know that in like psychiatric and therapy, they use like the psychiatrist would actually use MDMA to sort of help its patient. But whereas in clubs, I believe they use MDA or
That would be an adulterant, is it? It's the one which is similar, no?
I think what people do take traditionally, usually what people want when they go to clubs is still MDMA, but like there is a history of like MDA being like put in pills and stuff too, but it's basically just a molecule which is structurally very similar to MDMA, but it does have more like stimulant properties.
MDA has also been used in therapy.
But yeah, but it has been used in therapy.
so would you say it's safer to use MDMA rather than MDA? Or it doesn't really matter?
MDMA is less neurotoxic than MDA.
But they're very
MDA is like, it's a lot more like, takes a lot more toll on your body and mind. But it's not very common at all, like it's extremely rare.
I don't think you could say one was safer.
I guess
No,
with kind of what I was saying earlier about focusing on a specific substance, like it's not necessarily the specific substance that's harmful, it's like so many other factors. So that might be like how you're using it. Are you injecting it? Are you smoking it? Are you bombing it? Or how much of it you're using? Or like if you're using it with other stuff, or if you've got like a low body weight, or if your tolerance is high, that like it's difficult to say that MDA might be more dangerous than MDMA because it like depends on the person and the context.
You don't get MDMA really.
No, it's
And
like-
then to just touch on like therapeutic use of MDMA, I think it's mainly being looked into in terms of treating post-traumatic stress disorder, notably in veterans or other forms of trauma, and also at like quite microdoses to treat to help people in couples counseling. I saw a really touching video of a couple where the male partner was diagnosed with terminal cancer, and they had issues discussing his near death basically, and used mild form, small amounts of MDMA to kind of open up that discussion in that context.
Does
So
this make you empathize more, makes you feel like more loving towards people with that ecstasy?
yeah, so they would be the same thing, but then
Oh,
ecstasy
right.
might be cut with other stuff, but it is that when an empathogen, like we were
Alright.
discussing in the last session, so.
When people
Yeah.
want, what ecstasy traditionally should be MDMA, but what is classed as ecstasy now, is usually MDMA with other substances or something else. I mean, you can buy powder, crystal MDMA, which would just be the MDMA unless that's cut as well.
Right, and then it's put in like a capsule.
Yeah.
So I wanted to talk about cocaine and crack because I think they're very similar, and there's actually quite a lot of different misconceptions around them. So when we were talking in the previous session about kind of a traditional illicit drug user, when we think of cocaine, we think of high status people. or it being like an expensive drug, whereas when we think of crack, we think of it coming from lower economic backgrounds, that kind of thing. What's interesting is that crack and cocaine are actually pharmacologically very similar. What's different about them is the route of administration. So with cocaine, you'd be sniffing it. With crack, you'd be smoking it. So because crack is going to be having an effect on your brain more quicker, it has a higher addictive potential, and you're going to have to use it more often in order to those things. So in that sense, the way that we're using the substances, crack would be more harmful than cocaine. But then if we think about how some people might be using cocaine with alcohol or using quite a lot of it compared to a small amount of crack, I think it's difficult to compare the two. But there is definitely a lot of social stigma around crack cocaine, I think. Equally, I thought I'd just point out that when you dissolve them both and inject them, they have the same effect. So they are pretty much the same substance, but it's just different context and different ways of using them. What I did want to point out as well is that the disparity is very big in the States, but in spite of the similarity, the criminal penalties for possession of crack versus possession of powder cocaine is very different. So possession of 28 grams of crack cocaine yields a 5-year mandatory minimum for a first offense, whereas 500 grams of powder cocaine would prompt a safe sentence. So it's quite different. I think the disparity in the US has been reduced massively, but there's still a lot of work there. And if you think about how we're criminalizing maybe more marginalized communities for using crack cocaine, which is virtually the same substance, I think it can be quite harmful. Yeah, did you want to say something?
I don't know if you're talking about other talks, but what's the problem with cocaine and alcohol? Why is that mixture?
So when you use cocaine and alcohol at the same time, I mean, mixing any substances is harmful, but when you mix cocaine and alcohol, cocaine's an upper, alcohol's a downer. So it kind of, to simplify it, it sounds like mixed signals to your heart, which can be more damaging, but then equally it creates a different chemical called cochiethylene, which is quite harmful to your liver. So already using drugs can be quite harmful on your liver, but when you have the chemical cochiethylene, it can be even more harmful.
Is that cochiethylene, is that immediate danger, is that more long-term damage?
More long-term damage, but then in terms of impact on your heart, when you are, I think it's when you use cocaine, you have a 20 times higher likelihood of having a heart attack, whereas when you have cocaine and alcohol together, that's 4 times more than that, so 80 times higher chance of having a heart attack, which is I don't like scare tactics, but
yeah.
it is interesting, you know. Cool, so when we talk about amphetamine and methamphetamine, I think there's a similar kind of stigma when they're actually quite similar compounds, and it really depends on the context in which you're using them. Particularly in the States, methamphetamine is seen as quite a problem and is associated with people from lower economic backgrounds. But then equally, when we think about how these substances are used therapeutically, they certainly are legitimately sold at the moment. So Ritalin or modafinil, other variations of that, are amphetamines that are being used for therapeutic purposes, for attention deficit disorder, or it might be for people, I forgot the name, for people who sleep too much. Yeah, narcolepsy, it's used to treat that. Or for instance, for people who have issues with their weight, it can be used sometimes in microdoses to help them manage weight and that kind of stuff. And depression as well. Actually, amphetamines are used to treat depression. Methamphetamine, there's desoxin, which is also a therapeutic use of methamphetamine.
What's the meth?
So it's like meth, what you would think of as meth. Cool. There's also kind of this, I think in the States, there's these billboards that you have where it's this is someone before they took meth and this is someone after they took meth. And the kind of stereotypically they'll have quite bad teeth, which is called meth mouth. What that actually is it's just when you use meth, it reduces the amount of saliva you produce. So it just means that you're more likely to have dental problems. But on top of that, it's if you consider other social factors, maybe I don't know, not having a house or not having the ability to brush your teeth very often, it kind of adds to that. So there is this stigma around meth being more harmful, but really it's more related to social circumstances. All right, when we look at psychedelics, there's also a lot of misconceptions around that. So effects can be very variable with different psychedelics. I think the important thing to emphasize is that psychedelics are generally not physically harmful, but are more psychologically harmful. And it's variable because it depends on I think Zinberg wrote a piece of research on mindset and setting. So things that come into account when you take psychedelics are where your mind space is at, what your like set is at, and where your setting is. So are you in a like riot, or are you in a park with your friends? All these things can have an impact on how harmful psychedelics are. Equally, so whereas I would say with traditional psychedelics, such as magic mushrooms, acid, and ayahuasca, there have been no recorded deaths from psychedelic use. With more recent synthetic analogs of hallucinogens, like the, what are they called, the N-bones, and the DOB, DOI kind of compounds, there have been deaths reported with that. So it is kind of interesting to see how like synthetic analogs of hallucinogens might have very different properties to traditional psychedelics. And lastly, I wanted to talk about heroin and other opiates because I think there's so many misconceptions around that. I think just the biggest misconception is that heroin is more addictive than other substances. I would disagree with that, and I think heroin is not more addictive than other substances. I think it really, if you think about what I was saying earlier about the biopsychosocial model of addiction, it's social, psychological, and physical factors that would make heroin more addictive for that specific user. So things like injecting, obviously, is going to have a faster acting effect on your body. That's going to be more addictive. But I mean, I guess if you think about, just to go from one extreme to the other, if you think about like injecting heroin in an alley versus like using prescribed tramadol for pain management, they're virtually the same substance, but they're used in completely different contexts. So I think it's important to question a little bit like the addictiveness of the substance itself rather than the context in which it's used. Just to address that, there's no evidence to suggest that you have one hit of heroin and you're hooked for life. Again, it can be quite unpleasant, and people can use heroin for one time and agree that they don't really enjoy that experience and they don't want to prolong it further and kind of stop their use of heroin there. I also wanted to point out in terms of withdrawal, a lot of the kind of ideas that heroin is addictive, I think are linked to the fact that withdrawal from opiates can be quite uncomfortable. And can be a factor in you wanting to use again to alleviate symptoms of withdrawal. But these are non-fatal, where they are very uncomfortable and quite psychologically challenged. They would never lead to death in itself. Whereas if you think about alcohol, people who develop alcohol dependency to the extent that if they stop drinking, they can develop really severe symptoms of alcohol withdrawal and die. It's thinking about like the harmful effects of heroin versus like other substances, just to bring it into question a little bit. I also wanted to add that not all, but most deaths related to heroin use are not actually related to heroin use itself, but its combination with other depressants, notably use with alcohol or benzodiazepines like Valium. It's those cases where when you mix all those together, your breathing slows down to the extent that you go into respiratory depression and then you die, but it's not the heroin itself. We can say that like, if we're talking about them, then we can say that alcohol is equally like a really addictive, harmful, fatal substance. And what I did want to point out as well is that it's been a while now, but it's a lot more widespread in the UK, and particularly Wales, which is really good with that, and Scotland. But there are now opiate antagonists such as naloxone, which can reverse the effects of heroin overdose completely. So it's called naloxone, and it basically is like you can do it in several forms in the US. It's like a spray you put in your nose or in the back of your throat. Here it's like an injection you put in your muscles, and it reverses opiate overdose completely. So it's kind of like that, you know, in Pulp Fiction when they give her an adrenaline thing, that's not how you would deal with heroin overdose. Instead, it would be an intramuscular injection of naloxone that would reduce that. Think about so these are your receptors, yeah, and they're full of heroin. And when you have an opiate antagonist, it blocks it so that no more heroin can go in it. So it stops the effects of overdose and makes your receptors unable to take in that heroin that's, you know, starting that.
Because I had like a friend that had a really bad trip from, I think, ecstasy, but it was like really bad quality ecstasy. So she was tripping really badly, like everything was going down. And they rushed her to the hospital, and I think they injected a tranquilizer, so I wasn't sure whether it's like this.
So with naloxone injections, it's actually, you could do that to me right now and I would be okay. So I think it's a lot of the times when emergency services or even passerbys are not sure what kind of substances might be causing the problem at hand, they tend to just inject naloxone anyways as a measure in case it is someone who's going into opiate overdose. It's really not helpful.
So something like, it's not something you were injecting someone with, because if it wasn't that drug, it'd still have no effects on them.
Yeah, exactly. So it's just it's a really good.
What's about, you said earlier that for like a cocaine overdose, you wouldn't use an adrenaline shot to the heart. What would happen to someone having a cocaine overdose? Is it the same thing?
I think if you like a,
Probably, tranquilize them. So like,
because
down,
it has the opposite.
it'd lower the heart rate.
If you gave someone a tranquilizer when you've got the drug,
Yeah, it could do, yeah. 'Cause if they're all down and then you get the tranquilizer, that could actually kill them.
Then you just don't have too much.
Yeah, I don't know what Tarantino was thinking.
A tranquilizer because if she was having a family trait, if you give somebody like a benzodiazepine, that's like an anti-anxiety effect.
And it also kills the effect.
Like she thought she was dying. She was really paranoid. She was dying.
It might not have even been that there was love.
And she was hallucinating like crazy because she felt like she was in a different dimension altogether.
A negative, like there's a misconception that MDMA is always positive. It is completely normal to have a negative experience with MDMA. And when you have, because MDMA is slightly psychedelic, if you have a negative experience with it, it can be really, really intense. It's not an abnormal thing. I know lots of people who think that they've had abnormal experiences.
Right. I think also depends on your state of mind, like before you take it.
Did she,
Yeah, so
did she go to a club and take it?
She took it as well. I mean, I think so.
Imagine,
Because I remember when she came back home, I think they were at a rave or something.
imagine the environment is very intense.
And she took it like with people she met for the first time, so that could also like contributed.
For sure. Right, so I just wanted to sum it up by talking about drug-related harm a little bit. So, one of the misconceptions is that legal substances are less harmful than illegal substances, which is untrue, particularly if we look at drug-related deaths. So, there are more deaths related to smoking tobacco and use of alcohol